Professor Hazem El Beyrouti stands as a distinguished authority as director of the Department of Vascular and Endovascular Surgery at Pius Hospital, affiliated with the University of Oldenburg in Germany, an associate professor and head of the Division of Cardiac and Vascular Surgery at the renowned Johannes Gutenberg University Mainz. Professor El Beyrouti has played a pivotal role in redefining modern approaches to complex cardiovascular conditions, establishing himself as a reference in the management of aortic disease. Certified by the German Society for Vascular Surgery, DGG, his reputation for clinical excellence extends across Europe and into the global medical community. Professor El Beyrouti's academic footprint is equally profound. His research, focused on complex aortic procedures and endovascular innovation, has yielded over 50 peer-reviewed publications and contributed significantly to clinical advancements in aortic remodeling and vascular intervention. Among his many achievements, he developed a pioneering surgical technique that is now tied to his name, an enduring milestone in the evolution of cardiovascular surgery. As a respected member of the Cardiothoracic Surgery Network, CTSNet, his insights and leadership continue to shape the future of the field and inspiring the next generation of surgeons worldwide.
Good afternoon. We are pleased to start this session about innovations in interventional medicine. And we are pleased to hear Dr. Hazem El Beyrouti talking about revolunizing aortic dissection treatment.
Yes, yes.
Revolutionizing. Revolutionizing.
Thank
Please,
you.
Dr. Beyrouti, the
Thank
floor is
you.
yours.
Thank you for the nice presentation. Really, it's great. I didn't. Really, it's not easy to be here again in my hometown, Tripoli. Thank you. Thank you. So, dear chairpersons, dear colleagues, I would like to talk today or to discuss with you today about the aortic dissection and the new innovative medicine and treatment in this field. So this is my disclosures. Actually, aortic dissection is a serious condition, and when a tear in the intimal layer of the aorta allows the blood to flow into the aorta, and this leads to formating a new lumen, which can called the false lumen. That means we have two lumen, the true lumen and the false lumen, and this can compromising the normal flow into the vital organ, which is a life-threatening strategy and which is life-threatening condition. According to the Stanford classification, when the ascending aorta is involved, we talk about Stanford type A. When the descending, and this status need for an emergent surgery. And when the descending aorta is only involved, we talk about Stanford type B dissection, and this could be managed medically or endovascularly by TEVAR implantation. King George II was one of the first famous patients diagnosed with type A dissection, and his case helped bring attention to this serious condition. Statistically, aortic dissection affect more males than females, as you can see, and in the last recent years, you can see a significant increase of the prevalence of the disease. It's very important not to forget. 1954, Professor Dbeiki, or Michel Dabri, the famous Lebanese American professor in Texas Heart Institute, performed successfully the first replacement of the ascending aorta with the Dacron prosthesis. And since that, over the years and through a lot of innovation, we had a multiple variation of aortic replacement with hemi-arch, total arch, with the Russell or elephant Russell Khartoum into the descending aorta with various numbers of zone implantation into the aortic zone from 1 to 0 until 3. So I would like to present for you a case of a patient who in 2004 was admitted to our department with a diagnosis of aortic dissection. The diagnosis was determined, as you can see, by MRI, which is usually atypical in such settings. Normally, we made CTA. But anyway, as treatment, he became an emergency replacement of the ascending aorta with a Dacron prosthesis, with reinforcement of the reconstruction with the PTFE patch. So the idea with the replacement of the ascending aorta to get a positive remodeling of the aorta, as I said, we have two lumen, the false lumen and the true lumen. And the false lumen is not anatomically. That's why through this operation, we tend to exclude the proximal tear in the ascending aorta and to get a positive remodeling where the true lumen, as you can see, will expand and the false lumen will be shrink and will be thrombosed. This is very essential in treatment of aortic dissection. But the problem here that 40% of patients developed aneurysmal generation after repair. Otherwise, patency and aortic diameter are very important predictors in outcomes in aortic dissection because patent false lumen increase the risk of aortic dilatation and ruptures risks. Back to the same patient. After 14 years, he come again to us, and in follow-up CT, you can see here all the patient under controlling, always controlling CTA follow-up yearly or maybe every 2 years. It's very essential also for these patients. As you can see here in the CTA of the follow-up, we had aneurysmal degeneration of the rest of the dissected thoracoabdominal aorta, especially in the arch, with diameter for more than 65 millimeter, which is indication for surgery. And as the patient is young, we decided to perform frozen elephant trunk, which is replacement of the whole arch and descending aorta with the hybrid prosthesis. The frozen elephant trunk has excellent aortic remodeling, better than only ascending aorta. As you can see here in one of my publications, you can see to compare the aortic remodeling between the frozen elephant trunk and between the only ascending aorta replacement. We have here better aortic remodeling, which means better outcomes. The results are 75% for 10 years survival rate and 93% reoperation free rates. Back again to these patients. 6 hours after the operation. I'm gonna not tell you that I'm Superman or our team is Superman. We have also complications, and we should let you show this art of complication. By the same patients, we had a ruptured of aortic, thoracoabdominal aortic dissection because, and that's why the patient was unstable at the intensive care. So in the CTA, you can see hematothorax and contained ruptured of the aorta, which is disaster for us and first of all for the patients. That's why I decide directly to take the patients in the operation room, in the hybrid room, where I have my Siemens big hybrid room, and I implanted a TVAR, a stent into the aorta as distalization of the reconstruction, as you can see here, the deployment of the TVAR in the thoracoabdominal part of the aorta. After ballooning the stents, the DSA showed a further perfusion of the false lumen. It means we have still the problem. We should treat, we should attack. That's why I decide again to exclude the false lumen with a system called cork in the bottle, سدة الأنينة. It's a new device. It's a new technique. It's innovation of our century. So the first paper about the candy plaque was published by the Hamburger team, Thilo Kolber. Dr. Ahmed, you know, of course, the team. So, as you can see here, candy plaque consists of self-made TVAR modified stents which is implanted or which will be implanted in the descending aorta to exclude this lumen. And here we have a good remodeling in this paper by 7 patients. This was my diagram sketch of the candy plaque. As you can see here, I have 100 millimeter long of stents, and in the center there is a channel of 25 millimeter designed for anchoring the implanter, the cork, in the neck bottle to exclude the ruptured false lumen. So, at the same OP room, we didn't leave the operation room, the hybrid room. I cannulated and I placed a rosin wire in the celiac trunk and another staph wire far away in the false lumen. And after that, I advanced a candy plaque stent and I release it, deployment 2 centimeters above the celiac trunk, as you can see, and then occlusion with Platzer 22 millimeter. And this was the post-operative CT, as you can see in the 3D rendering. The patient was discharged after 8 days home. According to my recent publication this year's, after 3 years, we observed a good remodeling with an expansion of the true lumen, as you can see, the C, and retraction or shrinkage of the false lumen, and is significant, as you can see here. P is less than 0.005. Here, I would like to show another case where a patient, also with the same concept, but by this patient was the first worldwide patient and is documented and published also by my group. This patient is the first patient worldwide who get double candy plaque in his body. And the patient till now is alive and under follow-up. This is the third case for today. I want to introduce for you a 77-year-old male, young old male actually. In Germany, every patient still 70 years old should be called as young patients. So the patient has aneurysm and dissection, distal dissection, local of the thoracoabdominal aneurysm, but the patient, due to his medical status, respiratory, is unfit for open repair. That's why, after talking to the patient and to his family, I decided to perform an endovascular repair with a branched prosthesis. Through a puncture in the groin, there is no need for incision. There was no incision by this patient. And as you can see, here you can see my plan, how look like my plan after the CTA. To get a better or a safe reconstruction of the thoracoabdominal, I should take every measurement of the aorta, of the arteries, celiac trunk, SMA, left renal, right renal artery, iliac common artery, hypogastric artery, and external artery. I should take not only the length and the diameter, but also the angle of uptake of this artery. And after 6 weeks, I had this stents, which I implanted. Here you can see the release according to the anatomy. Here you can see the SMA, the celiac trunk, and here the SMA, and here the left renal artery, and then the right renal artery. After implantation of the stents, I cannulated all the destination artery. Here we have the celiac trunk. Here we have the SMA. I started by the SMA, then the celiac trunk, and I implanted after cannulation also bridging stents between the first main stents till the destination arteries, as you can see here. Here also implantation of these bridging stents to the renal artery. And this was the post-operative CT rendering, as you can see. And the patient was discharged at the fifth days post-operatively. And this operation were, as I said, done only per puncture. There was no need for incision. As conclusion, false lumen occlusion is our destination to get a positive aortic remodeling. Innovation in our field is essential, especially in the combination with the artificial intelligence, and this will become soon as possible. And as you saw, lifelong follow-up for those patients is mandatory. Thank you for your attention.